So I'm just going to start off by talking about the role of the GMS in precision oncology. So my background is that I'm a medical oncologist and consultant in oncogenetics at the Marsden, clinical director of Genomics here at the Marsden, and the cancer clinical lead for our GLH. So just to give you a little bit of background as to how we got to where we are with genomics. About 4 years ago, NHS England decided to alter the way in which genomic testing was undertaken in England. And this is unique to England, so the devolved nations have been exempt from this reorganisation. At that point in time, there were around 32 labs around the country doing some degree of genomic testing. But the type of genomic testing that was provided by each hospital and for every patient was different depending on where they were tested. Some had centralised funding, some had no funding. And so NHS England decided to bring all of the genomic testing together under one umbrella, both for inherited disease testing or inherited and rare disease, and also the testing that we undertake on cancer patients in their tumours. In order to do this, they split the country up into 7 regional areas, and for each regional area, we became a genomic laboratory hub region. Ours, as you can see, is on this London North. We've since been renamed or rebranded as North Thames, and we cover essentially North, East and West London and the supporting areas that feed into that. The genomic laboratory hubs in the GLH regions merged with what used to be the genomic medicine centres, who delivered the 100,000K programme, and these formed the next group, which is the Genomic Medicine Service Alliances. Within this, each of the hubs has a single lab which delivers the germline or rare and inherited testing, which for us is Great Ormond Street, and one lab that delivers all of the somatic and cancer tumour testing, which is our lab, the CMP at the Royal Marsden. Slow to come up. So these are the main constituent hospitals which feed into the North London Genomic Laboratory Hub. So you can see this is led by Great Ormond Street, and these are the main hospitals, and then all of the other hospitals in our region, and we include Essex as well as large parts of the southeast, feed into one of these hospitals and then into our hub lab. So the background of the genomic laboratory hubs and the genomic medicine services was really quite aspirational from NHS England. They wanted to build on what had been put together from the 100,000 genome service, and they wanted to provide a diagnostic national whole genome service and arrange for patients to be able to access the same testing no matter where they were in the country. They wanted all of this data to be available with de-identified patient data to facilitate research, and they were aiming to push towards having large panels so that all patients who were tested had much greater genomic information available, which would be useful going forward for things such as trial recruitment or disease relapse. They were also hopeful that we would be able to set up corresponding programs to utilise targetable mutations. So if, for example, we identified a druggable mutation in a patient for which there was a drug available but not necessarily licensed in that tumour type, that we would potentially be able to set up a stream whereby patients could access that sort of treatment. And this is not set up yet, but is something which NHS England is still working towards. In order to undertake this, they have the test directories, and this is how it is decided which patients will be able to access which testing across the country. So as I said, the national test directories, of which there are 2, define which tests a patient is eligible for. We have the ones for all of the inherited testing, or the rare disease directory. For each of these, there are eligibility criteria such as type of tumour, age of diagnosis, or any other molecular features. And there is also a national test directory for somatic testing, or the cancer directory. The difference with this is that if your patient has a tumour which is in the test directory and which meets the criteria, that patient is able to have that testing performed and the funding is centralised. So you no longer have a fight between oncology departments and labs about who pays for what testing. At this moment in time, that is now in place. So any of the hospitals that feed into the North London GLH can send eligible patients' tumours to our centre and have that testing provided. And as I said, this is based on what is in the test directory. And we have version 1 of the test directory, which is currently in place. There has recently been a submission process to update the test directory, which is recently closed, and the submissions are currently being reviewed. We're expecting submissions that have been approved to be added to the test directory, hopefully in July of this year, and then there will be a new process started, probably August or September, for the next update. As I mentioned, there's also a National Diagnostic Whole Genome Sequencing Service, which is relevant currently for some tumour types. This is the current setup for the Whole Genome Sequencing Service. So at this moment in time, we've just started with phase 1 of the Diagnostic Whole Genome Sequencing Service, and the patients that are being accepted for whole genome sequencing are patients who have a new diagnosis of sarcoma, patients with paediatric tumours, and that's currently defined as anyone under 21 years of age at diagnosis of their tumour, and patients who are newly diagnosed with acute lymphoblastic leukemia or acute myeloid leukemia. Any of these patients who have fresh frozen tissue available, so they're not accepting FFPE, can be identified for whole genome sequencing and have that tissue sent for DNA extraction to GOSH. GOSH will then extract the DNA and do the QC checks to make sure that there is sufficient quality and quantity of DNA for whole genome sequencing. This gets sent then to Birmingham, who will do plating, and then send it on to Illumina, who will be running the whole genome sequencing. They then send this to GEL for reporting, who then send a technical report back to the Genomic Laboratory Hub, where it will be reviewed at GTAB and the final report issued back to the original clinician. This process is currently at best slated to take around 6 weeks. So at this moment in time, it is being offered alongside standard of care testing, which has a much faster turnaround time. But the aim from NHS England is that as this process gets up and running and we're able to add further indications to it, that they will be able to significantly reduce the turnaround time. But what we're here to talk about tonight really is about the NTRAC testing. So NTRAC was a surprise addition to the test directory in that it came through as an accelerated request when larotrectinib received tumour agnostic approval. So we went live with phase 1 of NTRAC testing in April of 2020, and this included patients who had tumours which are known to have a higher frequency of NTRAC fusions, including GIST, thyroid cancers, Spitzwood neoplasms, paediatric tumours, and secretory breast tumours and salivary gland tumours. That's obviously quite a limited number of patients. We went live with phase 2 in late 2020, and this was then extended to all solid tumours who had metastatic or locally advanced disease, who had failed standard therapies but were fit enough for further treatment if found to have a mutation. We're now waiting for an approval to go live with phase 3, which will allow us to test all patients with solid tumours who have not yet reached the end of the treatment line, so being able to test them at an earlier time point. This is what it looks like on the test directory. For every solid tumour, there is now an entry on the test directory offering NTRAC fusion for structural variant detection by any methodology, by NGS panel, where they would otherwise be eligible for an NTRAC inhibitor. In terms of how to request this, this will be gone through in a little bit more detail later on, but essentially we have forms and further information available on our website, and there is also forms and information available on the North Thames GLH website. On this, there are also contact numbers for any sample questions or technical questions, so that you can talk to one of the scientists to make sure that you're sending through the appropriate sample or the appropriate form. This is what the request form looks like. You can complete it and send it with a sample. It's very straightforward. You just have to fill in the patient details and your details and tick the appropriate box. And then this gets sent together with an H&E section with the tumour marked and 5 10 micron mounted sections. So I guess the next steps for here from us are to go live with the phase 3, which will allow access to more patients, but until then we're currently accepting all phase 2 patients. So any who meet those criteria of having essentially exhausted standard of care options but still being fit enough for treatment can have this testing undertaken. There will be some further updates to the test directory currently under review, and so additional tests are likely to be added probably in July of 2021. And following this, they will open for the next set of submissions. So if there are any clinicians or molecular pathologists out there who have identified something that is lacking in the test directory, and trust me, there are a fair few of those things, please feel free to start thinking about a submission and what else you'd like to see in the test directory. I'm just going to pause at that moment and just check if there are any questions before we move on to Professor Forster.